Hello, I'm Dr. John Cruz, and today is a question and answer session with the jump off point being the video I released a few days ago about ketamine for ADHD. Does it help? Is it any good? So I'll recap that in just 1 or 2 minutes, and then I'll be open for questions. And the questions can be on that specific video or other ADHD topics or mental health in general. So the recap is that in the last 2 decades, there's been a large amount of data supporting that ketamine is a quick, effective treatment for depression. Does not mean that it works for everyone, but it has a high success rate even in people who are treatment resistant previous chemicals, previous antidepressant drugs. It works very quickly in that most people get some substantial, robust response within a few hours. That response from a single dose seems to peak at about, and this is an average because individual results certainly vary, so peaks at about within 24 hours, and then most people still retain at least some benefit for a week, but it tends to dwindle after that. So the optimal frequency of treatments, how long someone needs to continue treatments to stay out of depression, certainly varies from individual to individual, but there are not yet clearly established rigorous studies to show what's best practice. Um, the only FDA approved use for ketamine for depression is the Spravato nasal spray form, which is the S enantiomer of ketamine. There's debate as to whether the S or the R is actually more effective for glutamate blocking or for antidepressant action. That's not clearly established. There are certainly clinics that are using IV delivery, IV as a bolus, so all at once, IV over the course of about 40 minutes, intramuscular injections, subcutaneous injections, oral treatments, all of which need more work, all of them for depression. And I actually made this video in November of last year, but had to re-record it because of sound issues. And I rechecked the data out there, although I found a larger number of ketamine clinics who are advertising that they treat ADHD. And when I checked PubMed and other sources, there is not a single controlled, rigorous study. There aren't even case reports that have been written up showing ketamine to be effective for ADHD. That doesn't mean it isn't, but all of those sites actually claim there is research showing ADHD to be effective. Now, there are certainly individuals, anecdotal reports of people getting dramatic responses. Many of those are people who are probably having their depression or anxiety addressed by the ketamine, and that we know that depression and anxiety symptoms can mimic or imitate ADHD. It certainly is possible some people get true dramatic direct benefit for their ADHD, but that remains to be seen. How ketamine works for depression is still controversial. It is a strong NMDA blocker, so that's one of the glutamate receptors that's particularly prominent in the forebrain. But other glutamate blockers don't seem to improve depression and particularly don't improve it quickly. There's study out of Stanford and a few other smaller animal studies suggesting that an intact mu opioid system was necessary for its action. So if you block that with naltrexone, you block the antidepressant effects. That's, I think, came out in 2018, and I have not seen substantial studies replicating that yet. So how it works is unknown. And again, I would not recommend this for treating ADHD. That's the bottom line. So I see there's already some questions. And so thank you for being here. Thank you for coming back if you've been here before. And thank you for showing up for the first time if you're new. So on to the questions. So Dennis, hi Dennis, says, why aren't ketamine lozenges prescribed more often? He had no idea that at-home ketamine therapy was even legal, but looked it up and was surprised at how little regulation there is. So again, In the US, when the FDA approves a medication, they are approving it for a specific indication, for a specific condition or cause or disease. And the requirements are that it shows efficacy and that the benefits outweigh the harms. They recommend it at a certain dosage range, but they do not require. I mean, that is not a requirement. That's not a law. That's not the dosage is just simply a recommendation. And the indication is also a recommendation. So the FDA explicitly says things can be used off label if the doctor has good reason to think that the benefits may outweigh the costs for that patient. So ketamine was approved, it was developed in the early 60s, approved in, I think, late maybe 68 or 9 for anesthesia. It's an effective anesthetic, and unlike most other anesthetics, which are universally sedating, this one doesn't suppress breathing, doesn't suppress heart rate and blood pressure. In fact, can boost those. So, particularly in trauma centers, in trauma situations, in war zones, and for pediatric situations where just intubating kids is hard because of the size of their airways, um, it's been a desirable anesthetic. So it's FDA approved for anesthesia, but that doesn't, and approved in an IV form, um, but that doesn't restrict how ill-defined efficacy for depression, or didn't show a distinguishing from the placebo group. The objections to some of those studies is that they were using effectively too small a dose. So with the oral formulation, and this is off the top of my head, I think it's almost, I'm going to be wrong. So it's substantially less gets into your body with an oral, gets into the bloodstream with an oral formulation than with an IV formulation. So subsequent studies looking at what are considered to be equivalent dosages suggests that the oral form is as effective, at least the proponents claim it is as effective as IV, and certainly much simpler to administer, given that there will probably be greater individual to individual variation with dosage. And we've talked about this in the high dosage video and others, that there's factors of absorption, distribution, metabolism all affect blood levels. So there'll be more variability with the oral form. That doesn't mean it's a bad thing. Although with ketamine, it's pretty clear from several studies, some people don't believe this, that so ketamine has not just anesthetic properties, so it knocks you out or puts you to sleep. It has analgesic qualities, which mean it relieves pain. It has dissociative qualities, so it makes you have out of reality, out of body experiences, and it has hallucinatory potential. It's pretty clear that at least some people, if not all, get antidepressant effects at dosages lower than the dissociation and lower than the hallucination. But again, with an IV delivery, you have more precise control over how much is getting into someone's blood. So with oral forms, you may have more risk of bumping up too high and then getting into undesirable psychiatric effects. But yeah, I mean, in San Francisco, I know there are practitioners who are just giving people ketamine to take at home with minimal monitoring. Interestingly, Spravato, the nasal spray form that was approved, it is approved specifically only, it's not generally approved. You have to certify that your office is capable of, so it has the capacity to monitor blood pressure, heart rate, cardiac variables, and keep the patient in a safe, calm place for an hour. I think it's maybe 2 hours after delivery of the treatment. And that's again because of the risk of hallucinations, including full-blown psychotic effects and dissociation, and because blood pressure can be rarely go up dangerously high. But within the first few weeks of Spravato being available, there were psychiatrists in San Francisco who were just giving the nasal inhalers, nasal sprays to patients to take home and use at home. So that would be an express violation of how that product was approved, but people do it. So I don't know if that answered the question as to why isn't the oral dose used more. Probably it's just harder to regulate what exact dose you're getting. But certainly way more convenient. The other thing is that ketamine clinics are a huge, huge business. It's like 300 million, if I'm remembering the numbers correctly, business in the US right now. There have been numerous bankruptcies, mergers, but they are making lots of money each time they deliver their services. If they just gave you a pill and had you do it on your own, they're not making that much profit. So that may be cynical, but that's where the market is right now. Hello, Wesley. So Wesley DeVries says, hey, doc, unrelated question regarding Wellbutrin. One of the side effects, greater than 10%, is anxiety. Then why is it given in ADHD patients who have comorbid anxiety? So that's a good segue into the top. So I do have this separate talk on anxiety and ADHD. It's an intricate interaction between the two, but we know all of the agents that activate norepinephrine that are sympathomimetic, so stimulant-like drugs, have their potential for causing anxiety. That includes Wellbutrin, it includes Adderall, it includes Ritalin, it includes all the extended release formulations, it includes Strattera. All of those have the propensity for causing anxiety. Um, it does seem to be dose dependent. The bigger the dose, the more revved up you're going to be. So, in the setting of ADHD and anxiety, many people, one is there can be confusion between the two. So, I've had patients who were given an anxiety diagnosis and actually weren't particularly anxious at all. People were noticing their hyperactivity, they're jumping from topic to topic, they're talking quickly, and interpreted that as anxiety, even though they weren't. So one is there can be confusion between the two. Two is that ADHD itself can contribute to anxiety. So if you know that you blurt things out, you may be more careful and cautious and anxious about what you're going to say in a social situation. If you know you make careless mistakes from forgetting things, then you might be obsessively going over checklists in your head or recounting, did I do this, 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 and this, because I'm going to forget. So ADHD can strongly contribute to the development of anxiety. And if you have an agent then that's taking successfully addressing your ADHD, it may well effectively treat the anxiety as well. So that the sort of paradigmal story of a hyperactive little boy who's running around the classroom, looking at the window, playing with the ball here, dropping it, going and tagging his friend, running up to the teacher, tugging on the teacher's pant leg, restlessly moving from topic to topic, and then on Wellbutrin or on a stimulant is sitting there calmly. Some of that is because he's able to focus on what he wants to do at the time. He isn't distracted by himself or by things in the environment, and he can focus. So that's would be hopefully that answers your question, Wesley. So I'll actually go further with the Wellbutrin and anxiety. So Wellbutrin is FDA approved for treating depression. It's also FDA approved for smoking cessation in the product Zyban. It's also a component of Auvelity, which is the fast-acting oral agent where its role there is to block dextromethorphan's degradation because the 2D6 liver enzyme is what breaks down dextromethorphan. Wellbutrin inhibits that. But getting back to depression and anxiety. So depression and anxiety overlap extensively. There is sort of most of our other antidepressants, so the SSRIs and the SNRIs have been well documented for helping with pure anxiety conditions such as panic attacks, even in the absence of depression. Wellbutrin hasn't been found to be helpful directly for panic attacks and pure forms of anxiety. On the other hand, there are many, many doctors, psychiatrists included, who will not use Wellbutrin in an anxious, depressed patient. And I was actually fortunate early in my training to, when I was a resident, there was a patient, this was 30 plus years ago, and I'm not remembering what else was going on with him or why Wellbutrin was tried. He was so anxious, jittery, shaking, hospitalized for depression within several days on Wellbutrin. His depression alleviated, his anxiety went away, because for this gentleman, his anxiety was a subset or a feature or an aspect of his depression. So even though many people avoid Wellbutrin in anxious depression, and I'm not saying blithely jump ahead with it for everyone, but I'm saying it should not be ruled out just because it itself doesn't directly treat anxiety. If that individual's anxiety is an aspect of their depression, they may well get a good response from Wellbutrin. So, so Mr. Disco said his doctor just told him he won't consider prescribing intuitive guanfacine because it wasn't approved for ADHD in adults, and he and his pharmacist were only aware of one adult patient on it. Well, and that just is so, I'll say it, glaringly stupid, or maybe willfully stupid. So again, to get back to the point, the FDA, when they approve drugs, I left this out, approves drugs for a certain indication, recommends a certain dosage range, and recommends a range or approves it for an age range of individuals. Every one of our ADHD treatments, and this is unique in psychiatry, where mostly antidepressants, antipsychotics, other agents are tested and approved in adults. And then we don't know whether they really work in kids or not until you test them or approve them separately. The SSRIs as a class in general seem to be somewhat less effective in kids than they do in adults for depression or anxiety syndrome. ADHD, it's the opposite situation. Absolutely every drug in the US that's approved for ADHD has been tested and tried first in kids. And then, if the company, and again, the company doesn't need to get a specific indication for it, but usually sometimes they do. And I am not aware of a single case of any ADHD medication that is effective for kids that is not at least as effective in adults. So, as a generalization, it's somewhat idiotic to say, oh, this is only safe in kids. It's not appropriate in adults, safe or effective. Specifically with guanfacine, there are a number of studies looking at it, not just in kids, but as adults as well. I do have a talk on guanfacine. My own bias with guanfacine is I don't tend to use Intuniv, which costs more than 10 times as much for my patients. So the studies looking at guanfacine for treating specifically ADHD symptoms, and guanfacine does take a slow time to work. It is highly unlikely to rev someone up like any of our stimulants are. Um, but where was I going with that? So guanfacine works, it's effective, takes time. Oh, immediate release, extended release. So Intuniv is a special brand of extended release guanfacine. I almost always use immediate release, and there might be a different ratio number of studies, but there are as many studies looking at it, showing it to be as effective as the immediate release form as an extended release form. I dose it in the evening with my patients, so taking the immediate release form in the evening, and that greatly reduces, from what I've seen, the likelihood of daytime sedation or grogginess, which some people have with the extended release, even if you take it at night. So I, so again, there are numerous peer-reviewed published studies out there about the efficacy of guanfacine in adults. I'm just astonished that the doctor would pretend there aren't, or assume there aren't, or I don't know what's going on, and maybe even particularly the pharmacist. So I don't want to, I shouldn't be, I don't know what's going on in their heads, so I should not criticize their heads. I will just criticize their actions, therefore. So, jumping back to Wesley, apparently amphetamines, such as, for example, dextroamphetamine can increase cortisol and other corticotropic hormones, especially during evening. Are there ways to counter this, such as using medications? So we do have drugs. I mean, my my thought there is to not focus on the chemicals as much as are you seeing a problem that we are sure is due to increased cortisol? And if I mean, cortisol varies a lot during the course of the day. It has a circadian rhythm. It varies episodically depending on what's going on. So just an increase in cortisol, particularly a short-term increase in cortisol in itself is not worrisome. I mean, my questions first would be backing down on original medications, usually before adding a medication to add on just to treat side effects. And particularly, I seldom would be adding something on just to treat a lab-based side effect when without objective evidence that there are physiologic or psychological implications for the patient at that time. But I can look into that. So Diane C says, hi again. And she's reminding me of ADHD. She has ADHD, depressive disorder, and OCD. Do you think it would be okay to get ketamine therapy for the depression, even though I have ADHD? Also, can ketamine help OCD? So, ketamine's far and away the most research is on depression. There's extensive use of it for pain control, with actually somewhat less research that I came across. So, pain and depression, I'd say, are fairly well established, well documented uses. And particularly in the pain realm, in both realms, the question of addiction and abuse are not trivial ones with this substance. Matthew Perry's death earlier this year was directly related to not just ketamine use, but to ketamine abuse becoming high. So it's a substance that many people develop tolerance to fairly quickly and need higher and higher doses. Um, so I know there's some research in PTSD and other anxiety spectrum issues. I am not specifically aware. I just don't know. Are there studies for OCD? But for someone who has ADHD and depression, to me, again, we know ketamine can treat depression. I'm not going to make specific recommendations for an individual like you because I don't have your full history, but I would say in general, having ADHD doesn't rule in or out the effect or benefit or attempt to use it for depression. So again, there are not case reports, but there are anecdotes in the online or on popular media, not in medical literature, of ADHD symptoms responding, usually in the context of people having depression and anxiety and other symptoms that respond as well, but at least one fairly prominent case where the person seemed to only have endorsed ADHD symptoms and that improved. Um, yeah, so I'm not hearing anything among the constellation of any reason not to try Spravato nasal spray for that combination of conditions. So more feedback. So Diane's getting back to anxiety. She's on Wellbutrin and generic Ritalin. She gets anxious sometimes even before taking those meds. And her psychiatrist has prescribed gabapentin to help deal with anxiety episodically, to take as needed. She rarely takes it. So gabapentin, FDA approved for seizures. If I'm remembering correctly, I believe I is. Gabapentin was the first drug and I'm not remembering even which company made it, but in the probably late 80s, maybe early 90s was the first company sanctioned with multi-million dollar lawsuits for the FDA because its drug reps were promoting gabapentin for bipolar disorder, promoting it for anxiety disorders, promoting it for a whole host of conditions for which it had not yet received any FDA recommendation or indication. On many of those topics, when multiple um, randomly controlled trials were done, gabapentin didn't seem to be particularly effective. I've certainly had many people over the years who came to me on gabapentin and swore that it was beneficial for their anxiety. It certainly can be sedating. It's certainly also used for sleep. Um, it tends to work quickly if it works because its half-life's fairly short. But the documentation, the rigorous research of how well gabapentin works for anxiety is pretty darn weak. That's all I'll say there. And the positive is that other than it can be sedating, it can be, people can start slurring their speech, people can fall asleep. It tends to be less powerfully directly sedating than benzodiazepines and less disinhibiting. Yeah, I know gabapentin is also used extensively for neuropathy, for HIV neuropathy, for diabetic neuropathy. I'm not remembering whether it got a full FDA indication for that. And the metabolite of gabapentin, brand name Lyrica, I'm forgetting what Lyrica's generic name, is approved for some indications that gabapentin itself isn't approved for. So Wesley DeVries is following up about the cortisol. He has premature ventricular systoles, but only during the evenings. Has come down after it gets off, after the immediate release dextroamphetamine wears off. I don't have I don't have more to say because I don't know enough about the effects, how strongly and how quickly and how chronically amphetamines effects on cortisol and the whole cortisol axis are. So Diane C says her stepsister's vet prescribed gabapentin for anxious dog. When he goes to the vet to get his clip, she says it works well. And she sort of laughs about that. I actually think that's some of the most compelling evidence. There are still skeptics out there who claim that antidepressants don't work at all, that they're not any better than placebo. I think that's a gross misreading of the literature. It doesn't follow that placebo responses tend to follow a different time course in terms of quicker response. It peters off fairly quickly. And I'd say the animal research. So SSRIs are widely used for OCD-like behavior, for depressive-like behavior in dogs and cats, and it's pretty darn hard to argue that your dog had a placebo effect, or I guess you could indirectly argue that the owner felt so relieved and certain this was going to work that that conveyed something to the dog. But in my experience, most pet owners have been pretty darn skeptical when their vet recommended or prescribed something. They didn't actually have a high expectation it would work. So Joshua Nixon asks, can I comment on the similarity difference between the effects of Strattera on MDMA? So I'm guessing the difference between Strattera and ketamine. So on NVMA. So one has to do with relative strength. Strattera, atomoxetine's most potent receptor interactions are with norepinephrine reuptake, norepinephrine transporters. I'm aware that it has some NMDA blocking action, but I don't know directly head to head compared to therapeutic doses of ketamine, whether that's higher or lower. I would imagine that it's likely to be lower. Ketamine itself also has actions on other receptor systems. I know with ketamine, some of the more recent studies suggest that it only blocks and binds the ketamine receptor when that receptor is already open to begin with. So we sort of talk about antagonists, blockers, agonists, something that binds to the receptor, and we talk about inverse agonists, so that's something that binds the receptor and has the opposite effect of um but it's actually, again, sorry, I'm being inarticulate. It's much more complicated than that because there can be different conformations of the receptor that are bound to more readily than other formations. So other than that, I can't say, but again, several other NMDA blockers, with memantine, the Alzheimer medication at the top of the list, but also lamotrigine, don't seem to be effective quick antidepressants. I'm not aware of Strattera having direct, quick antidepressant actions. With ketamine, some of the interest has gravitated toward whether it will pan out or not, some of the metabolites of ketamine. So maybe something that's broken down into it has a different profile of acting with different receptors, and that might be what's important. So that's a unfortunately not very complete answer to Joshua. So Mr. Disco, um, so I'm going to have to jump back to which topic. So Mr. Disco, I think we're talking still about the guanfacine. Yeah, there's more than one trial of guanfacine in adults with ADHD. I don't have the number, but there's more than one. Um, 20 milligrams of Vyvanse has them revved up too much, so it doesn't go away. I'll have to find a second option. So thanks for pointing out that although guanfacine in the form of Intuniv was approved as a standalone agent for treating ADHD, and we have extensive documentation it works, my impression, and from talking to other people in the field, other prescribers, and I think some amount of real hard data, is that far more commonly someone's taking guanfacine in combination with a stimulant medication. So even though that combination hasn't been tested as extensively as using it alone, it's certainly in real world being tested extensively. And one of the very specific uses of guanfacine is for people who are feeling too revved up, too activated on a stimulant. And the commonest protocol is stop the stimulant, start up guanfacine. When you're feeling physically comfortable with the guanfacine, then consider adding back the stimulant if you still need it. And one is that sometimes people get a positive response from a lower dose, but even on the same dose as they originally were, they often are not having problematic side effects. I'm going to cough anyway. The other thing I would add is that if 20 milligrams Vyvanse is too much, there is a 10 milligram Vyvanse, or Vyvanse, you can open the capsule and take half the pill. Manufacturers hate it when people say that, but there's nothing dangerous. There's nothing slow release or important about the outer capsule for Vyvanse. Yep. So Diane C was mentioning that her sister-in-law, stepsister's dog was taking gabapentin, not an SSRI. So I wasn't implying that it was, or I got that. I was shifting topics slightly because there's, I think, more extensive veterinary work on SSRIs. But again, both of them are showing, again, the critics, and it's very strange. Many of these critics say SSRIs can't, don't touch depression, don't help depression, but they are powerful, horrible drugs that cause withdrawal effects. And bad side effects. So they are incredibly strong, potent drugs that don't do anything for what they're intended to do. Doesn't, again, accord with reality or what I've seen. Not that some people don't have bad responses, not that some people don't have trouble stopping them. So Wesley asks, are there medications under development that you are looking forward to, such as a state of the art? Would love to see more videos. So I did release one um, video on centanafidine. So it's a triple dopamine, norepinephrine, serotonin reuptake inhibitor. That's the one that's the closest to being released for, presumably, for ADHD. I've also talked about Sunosi. Um, One is, this is anecdotal, but I can remember about the time I was finishing residency and I would go to the annual psychiatric meetings. So big meeting, 30, 40,000 psychiatrists used to go to them pre-COVID. I think the numbers have been a little smaller since then. And for at least 6 or 7 years in a row, and I'm not remembering which company, it might have even been Eli Lilly. So reboxetine was going to be a simple norepinephrine reuptake inhibitor improved for depression. And each year they promised, oh, we've gotten the studies in, we're finishing the paperwork, it's going to be approved soon. I mean, they even had put the money into investing in having a booth at the American Psychiatric Association, which I'm sure cost them thousands of dollars. And this went on for 6, 7, 8 years before finally that was abandoned. So many drugs can look close to approval. So I tend not to get my hopes up until they're actually on the market. Um, that that may be a cop out. What other approaches? I think it's sad that, as far as I can tell, nicotine receptor approaches have been abandoned, even though that seems to be involved in question or issue. There's certainly studies are aberrancies with ketamine or with NMDA receptor systems. So ketamine is actually a logical substance to be investigating, at least. Again, I'm not aware of formal studies going on looking at ketamine for ADHD from one area to another. So buspirone does seem to have some benefit for ADHD. Amantadine has some benefit for ADHD. The buspirone's a anti-anxiety medication, although other serotonin 1A agents, gepirone, have just been approved for depression. Amantadine, I have a whole talk on. I mean, that was originally an anti-influenza medication and then a promoting dopamine agent for Parkinson's disease. So I think we've seen as much spillover from existing drugs as we've gotten marked jumps in treatment from brand new drugs. Yeah, so Joshua's clarifying that he was more curious about the possible role of NMDA in ADHD treatment rather than for depression. I mean, I would say it's still most of the focus has been on dopamine and maybe dopamine norepinephrine in the ADHD field, just because there are more consistent or extensive documentation of abnormal processing in those systems. Um, there is some work on NDMA, and I don't know how consistent it has been in ADHD, so I'll just stop there. So Imran says, are people with ADHD less able to cope with stress or negative news? So one is that that's hard to objectively measure because you'd have to put people in a test situation where you're giving them stressful or negative news, which most ethics boards would say would be unethical. If it's real enough to be meaningful, It's probably unethical if it's so mild that, oh, you're not going to get a chocolate ice cream cone. You're only going to get a vanilla one at the end of this study you're engaged in. And that might be so trivial that we can't really measure it. But given that, particularly with hyperactive ADHD, emotional regulation is one of the prominent symptoms, and that means people's emotions tend to be bigger and harder to control. And if that's something in a negative response, then it would make it harder to deal with stress or cope with negative news. Now, just the phrase cope with stress is a pretty broad, open ended one. And one trait, again, this is somewhat hard to study rigorously, but many people with ADHD endorse. Yes, I'm scattered, I'm unfocused, I get distracted, pulled off track all the time. If there's a crisis, if there's an emergency, if there's something that has single mindedly pulled my attention in, I'm the one who's actually focusing and processing and dealing with it. So, and again, I haven't seen hard data on this, but I think among EMTs and other sort of emergency personnel, probably ADHD is overrepresented because many of those individuals actually do focus well in those situations, particularly if they're trained and know what they should do ahead of time. Um, so, so my answer would be twofold. Yes, many people with ADHD are more likely to be derailed by strong negative news, but there are certain situations where many of them seem actually to cope well with certain types of stress. So Miguel asks, is ketamine good for ADHD? And again, there's my whole video on it. My answer would be lots of clinics are claiming, and they're claiming the same things they were claiming a year ago, that there's research showing it's good for ADHD. That's just horseshit. There is not research showing it's good for ADHD. Whether or not it might help some individuals with ADHD is possible, but we don't have research on that. And it has not been documented or shown to be. It might, so I'll leave it there. Yep. So Diane's, again, referring to, so gabapentin has a fairly short half-life. Her stepsister gives it to the dog shortly before going to get his nails clipped, and it seems to calm him down. Good. So Amadi asks, can we develop tolerance to methylphenidate? So the topic I'll be talking about, I guess I'll be recording it this weekend, is several people asked me to comment on a study that came out, I think it's 28, no, I think it might even be 2013, at least 5 years ago, maybe closer to 10. It's about upregulation of the dopamine transporter system in people who've been chronically treated with methylphenidate. I won't spoil my thunder by talking about it too much, but it speaks directly to the topic of tolerance. So I might not even be titled tolerance, but I do have a talk here. It might have been the medication honeymoon talk. I've talked about it several times. And it's interesting. If you talk to the ADHD experts, they say for many people, there's some sorting out in the first days, weeks, maybe even a few months to figure out what dose is right. And then usually when we find a dose that's effective, that tends to work for years and years. And most of them would agree that there's still many people with ADHD who have day-to-day variation. They have that without medication. They have that even with medication. That's separate from tolerance. So the answer there would seemingly be most people don't. If you talk to substance abuse experts, they say all the stimulants people develop tolerance to, they develop tolerance quickly, and it's virtually 100% of people developing tolerance. So I did a survey. I took the numbers and crunched them in my own practice. So and this I did during COVID. So looked at 100 people who had been stable on their stimulant dose for a year. So we're not talking about any transitioning on or off or starting it new. So stable for at least a year. And then I simply looked, what is their dose a year later compared to the beginning of that year? And As I expected, slightly over 80% of people were on exactly the same dose, suggesting the same dose is continuing to work. And roughly equal numbers, so about 10% had actually gone up on the dose and 10% had gone down on the dose. Now, I think that number was skewed a little bit by COVID because in that time, anxiety was up, and anxiety, we've talked about anxiety and ADHD a little here today. Anxiety is a good reason for backing down on the dose of someone's stimulant. Um, but it was pretty clear that, at least in my practice, most people weren't developing tolerance. And yes, might be idiosyncratic to me. Maybe I'm giving a strong message you shouldn't ever need to or have to switch dose. On the other hand, given that 20% of people switch dose shows that I'm not. I mean, I know doctors who say, nope, you started at 30. I'm never going to go above 30 because that's a sign of tolerance, and tolerance is part of addiction. And that's a problem. Um, so I think my numbers show that I'm willing to meet patients where they're at, and they're willing to talk with me and discuss that. And again, that most people, and this was people on both amphetamine products, as well as methylphenidate. So I think, and it could be as simple as in a therapeutic dosage range, maybe most people aren't developing tolerance. Maybe it's when you're above your therapeutic range and closer to abuse range to begin with that you are running into problems with tolerance. Steve brings up there is rejection sensitive dysphoria, which impacts people with ADHD. I'm not. Yeah, so rejection sensitive dysphoria, and I've talked about this. It's one of my earlier videos. I get that the term really resonated with many patients, that they feel rejected by their families, rejected by society, that they behave or do some things that are different, but get extremely hurt, extremely criticized, extremely feeling isolated because of it. The person who's promulgated this view, and he waffles a little in some of his writings and talks, but most often he comes back to the claim absolutely everyone with ADHD has RSD. That doesn't correlate or correspond to what I see, and particularly, I think there's some ADHD individuals who are particularly impervious to any negative feedback that uh, rolls off their back like water off a duck. Um, there's something called positive illusory bias in kids. Up to 30% of kids with ADHD, at least 30% of boys show that. I think those are the type who may be not prone to RSD. So one, it is not present in everyone with ADHD. And two, well, three. Two is it sort of blurs what the definition is with emotional volatility or dysregulation or sensitivity. Most of the time, it's a much more specific set of feelings of hurt, rejection, uh, negative feedback, or criticism, but it can be a more amorphous emotional volatility. But three, I don't see it as particularly unique to ADHD. So maybe it's being a member of the LGBTQ community and treating lots of people who were treated horribly and differently because part of their brain worked differently. Or I think many conditions, like particularly neuroatypical conditions, ASD spectrum people, LGBT, ADHD, I think many of them have that constellation of all the features he describes as rejection sensitive dysphoria. So, Steve is suggesting that dosage changes I think would be more likely needed in someone who gains significant weight. Possibly. I mean, so one in my dosage talk, which was fairly recently, body size has some correlation, but it's a pretty darn weak one. I bring up examples of a large person who gets by on a small dose, normal sized people who required absolutely huge doses. If someone's gaining weight, then usually we're thinking that most of their weight gain is fat rather than muscle. I mean, if you're specifically bodybuilding, that could, but the way you just framed weight gain. And so that gets to distribution, not just absorption, not just metabolism. Gaining a lot of fat may not change your effective pool of where the drug goes in the body, except in case it's a highly lipophilic, highly fat selective compound. So gaining a lot of weight would probably affect your marijuana dosing more than it would your amphetamine dosing or methylphenidate dosing. Yeah. So Steve points out that RSD, the rejection sensitive dysphoria, is not something that's in the DSM or other formal diagnostic systems, and it's speculative. Again, I found many individuals particularly resonated with it or elements of it, but that's not always a good measure of how accurately it reflects things. So I shouldn't make random swipes at other people, but I was just researching. One of the most popular books still in the history of ADHD is something called Scattered Minds by Gabor Mate, who was a um, Hungarian Canadian general practitioner, no particular psych training. And much of his book on scattered minds sounds like a 1950s psychiatrist blaming mothers for bad mothering and not mirroring or matching their kids' trauma. And I've had lots and lots of people who identified with what's in the book. And I'm not saying, I mean, we know trauma is overrepresented in people with ADHD, but there are absolutely people who grew up in completely loving, supportive households with ADHD parents, even who develop ADHD not through any trauma. So it is not a universal source or cause of ADHD. I'm going off track there. But, so just because a concept is appealing to lots of people or resonates doesn't, it, I would say it reflects there's truth at some level in it, but how widely applicable it is doesn't say much on that. So Wesley had a question about Wellbutrin. So the question is, do I see regarding Wellbutrin, the patients who start on Wellbutrin somehow need more treatment, either have more psychiatric conditions or less treatment with respect to amphetamines? So I'm not sure if I'm going to answer this directly, but I'd say in the first decade or so of treating people, working with a lot of adults with ADHD, I was much more reluctant than my few peers who were doing it, because not many were doing it then. Many of them blithely prescribed stimulants. Again, the stimulants, particularly amphetamine products, do have clearly substantially the highest likelihood of success and help the ADHD symptoms to the greatest extent. But I was worried, maybe overly worried, about the risk of amphetamine induced psychosis because I saw it at much, much higher rates than the experts were acknowledging. There were notable features about my patient population that made that true and made that non-representative of the greater risks. Anyway, so I had lots of people who started on Wellbutrin just because they and I felt safer with it than with amphetamine, but I don't think it reflected, do they also have depression or not? Do they also have anxiety or not? Do they also have OCD or not? Do they also have PTSD or not? Because I think many of the conditions such as PTSD or anxiety that could be exacerbated by either Wellbutrin or stimulants. And again, we've already talked, they can both help with it, but they can't. I don't think there's a differentiation between the risks profiles of either drug with regard to other conditions. Now, something like psychosis, addiction, clearly there's a different profile of risks between Wellbutrin and amphetamine. But in terms of, I don't see other conditions, comorbid conditions is shaping where I would choose Wellbutrin versus where I would choose amphetamine, except with the substance abuse disorder. That's the concurrent diagnosis where very clearly I'd be much more comfortable with Wellbutrin than with amphetamine. So ketamine not available over the counter. I mean, the other thing I addressed in passing is that developed for anesthesia in the early 60s to the mid 60s, but starting at least in the 70s, 80s, 90s, the other big use of ketamine is special K as a rave drug, a alternative lifestyle drug, specifically taken for hallucinatory experiences, dissociative experiences, being out of touch with mind or body. And one interesting thing is that there are a couple studies suggesting particular parallel or similarity between ketamine induced hallucinations and near death experiences. So lots of the same imagery, lots of the same sensations seem to be present in the two conditions. So to that extent, ketamine was widely available, or not, at least available without a prescription, not legally, but more widespread than, again, you'd have to, until this millennium, you couldn't get it in any form other than an IV for anesthesia, except for, again, the black market. So CXVZF says Mindbloom is one of the organizations that does home lozenges for ketamine. Um, so Mindbloom, and I don't know, my understanding is it's a nationwide chain. I know there's branches in California. I don't know how extensive it is. I've had a patient who I was treating for ADHD and intermittent depression, who went to Mindbloom specifically to get ketamine. They never contacted me. So, one, I think that on the surface is bad practice, that at least you should ask what else the person's taken, what they responded to. Two is that they initially billed it that all these sessions would be supervised sessions. And after one initial session, she was just given, here, take it home and do it whenever you want. Oh, you should have your husband sticking around just in case there's a problem. That's one Mindbloom prescriber. It doesn't say the whole Mindbloom system works that way, but it was, depending on your viewpoint, either amazingly relaxed and meeting the patient where they're at, or amazingly lax and irresponsible. I mean, she was not thoroughly warned about potential for problems with it. So we have about a minute left. So Mr. AKA asks, who needs ketamine for depression when you can watch the Lord of the Rings extended edition trilogy? Well, my answer there would be, if you have ADHD, then you might really need something other than the Lord of the Rings extended edition trilogy. That might be, for some people, more an insomnia aid than an antidepressant, but to each their own. I actually haven't watched all of them. I enjoyed reading them 50 plus years ago. So Steve is commenting on lots of hallucinogens being used to treat PTSD, and I'd say there's more treatment going on than there is rigorous research. There is some rigorous research on all of those. Yeah, so There's a question about skin sensation on amphetamine, and I'll save that for another time. And Mr. AKI asks a final question about memantine, and memantine being a partial agonist at NMDA versus full antagonism with ketamine. Again, there's some difference also that ketamine seems to only block um, ketamine or NMDA receptors that are already fully open. So there's still complexities to these systems we don't know. And if we had the answers, we'd almost certainly have agents beyond ketamine that we're using right now. So that's where I'll end it for today. Stay healthy, stay happy. I've appreciated the questions. I clearly have a few things to go look up in more detail, but hopefully I will get back to you and have a great week.